Welcome, everyone. Today, we are excited to be having a disaster response collaborative fireside chat on trauma-informed mental behavioral health considerations. Next slide. The Pediatric Pandemic Network is supported in part by the Health Resources and Services Administration, HRSA, of the U.S. Department of Health and Human Services, HHS, as part of several cooperative agreements. The content presented here is that of the authors and does not necessarily represent the official views of, nor an endorsement by HRSA, HHS, or the U.S. government. For more information, visit hrsa.gov. Next slide, please. So you can get continuing education credits for staying until the end of today's session. You're welcome to introduce yourself in the chat and disclose what type of CE you're most interested in. We will give you additional details at the end of the session. And my apologies. I wanted to mention that Dr. Schreiber maintains the copyright and the trademark for SciStart, which you'll hear about, and has received funding from various nonprofit, federal, state, and local governmental agencies, and all views related to SciStart are solely his own. Next slide, please. We're excited that you're here today. Thank you for joining us. We know everybody's busy. This session is being recorded. The recording, the slides, and the various resource links will be shared online on the Disaster Response Collaborative website and via email within a week of this fireside chat. You're welcome to add your questions either in the Q&A chat box or the regular chat feature. And you can see which types of CE are available in the blue bar. Next slide. I'd like to turn it over to my colleague, Chris Gable. Chris, could you introduce yourself and then our wonderful speakers today? Thank you.
Thank you, Laura. So my name is Christopher Gable. I'm an ED physician at Children's National. I'm also one of the site leads for the PPN mental and behavioral health domain, and I run one of the subgroups for dissemination, sustainability, and policy within the mental health domain. And I have the great pleasure of introducing two of my colleagues. The first being Kira Mausa. So Kira Mausa is a teaching professor at Seattle University. She is a practicing clinical psychologist and affiliate faculty at the University of Washington, and serves as a co-lead in behavioral strike teams through the Washington State Department of Health, and owns Astrum Health, which is a consulting organization and educational group about disaster preparedness, resilience, and building that resilience in local communities. She has provided training to community groups and professionals regionally and abroad, and is the co-developer of the health support team. She has worked extensively with disaster survivors and refugees and has trained first responders throughout the Puget Sound and the United States on building adult mental health resilience. She is also the author of Why Therapy Works, The Psychology of Change. My other colleague is Dr. Merrick Chip Schreiber. He is a professor of clinical pediatrics at Harbor UCLA Lundquist Center and is a senior advisor to the Terrorism and Disaster Program at the National Center for Child Traumatic Stress and the David Geffen School at UCLA. He also serves as a lead for RAPM, which is the Western Regional Alliance of Pediatric Emergency Management, and is the chair of disaster response, the California Psychological Association. As mentioned before, he also developed the SciStart mental health incident management system and a step triage to care for at-risk patients and emergency medical responders. He is also the development of anticipate, plan, and deter and listen, protect, connect tools that are used a lot in disaster preparedness and mental health response. So I am very excited to hear what they have to say on these topics, and I'm going to turn it over to Chip for to start.
Well, greetings, everyone. Thanks for joining us today. I think we know who everybody is, so welcome. We're glad to have you. Some of you I know, others not quite yet. Wonderful to have our new hub site. So many folks from OU HSC on board, including the co-PI, Dr. McGee. So wonderful. So the idea today that Kira and I want to convey is to kind of shed some light on the psychological impacts of the four focus areas of the current DRC initiative, and how they relate to patient care and long-term risk and resilience, in events that would involve those types of situations that are highlighted in those four focus areas. And then hopefully to get to some concrete ideas about how you can expand your disaster planning and policy to more comprehensively address those mental health impacts. Next. And it's a small group, so we're really interested in not going through a lot of content slides, but really to have a discussion with you. But what we know is, just real basically that, incidents that involve chem bio, radiation, or God forbid, nuclear encounters when there's kids and parents are separated and there's reunification or tracking, and when there's a significant evacuation that often kind of goes along with the first two, there's a pretty significant increase in mental health risk for kids that we treat, for their parents, their caregivers, and also for those of us that take care of kids, our EM providers and staff. And we know that there can be transitory distress, but also significant new mental health risk at the diagnostic level. And the current thinking is when that happens, it's usually a combination of things like PTSD plus something else, like depression or anxiety. There's a relatively new diagnostic category in the system many people aren't familiar with called prolonged grief disorder. And there's modifications of PTSD and prolonged grief specific to kids. And we can talk about that if that's really of interest. We also know that these disaster risks really compound pre-existing histories of trauma and loss. If there's a concurrent psychiatric diagnosis, including autism or kids on the spectrum. And we know that when certain of the things that SciStart picks up, being separated from all of your caregivers, when you perceive a direct life threat to yourself or your family members in that index event, when you have extreme peri-traumatic helplessness, those all add significantly to the likelihood that you're going to develop a more enduring mental health impact than a short-term distress that resolves quickly without mental health engagement. We think there's things that can be relatively easily done to improve the ability to understand and serve kids who have mental health impacts after these types of events. Yes, it's more work, but we've been working hard in our learning collaborative over the last 3 years to make things more feasible, to streamline the training. Kara's done a lot to make some of my psychobabble more understandable and translatable into real world practice. We have a tabletop for our Learning Collaborative members that's coming up in June. And we've been working hard with several hub sites, Seattle Children's, UC Davis, and now OUHSC to integrate SciStart into EPIC. So there's a reduction in paperwork challenges. We know that that's a big issue. And I guess, just to sum up, we're really interested in increasing a trauma-informed approach. And in this case, the trauma is the mental health side of it. And, we have some different models. The Learning Collaborative, basically, we want to identify a high risk subset of kids after everyday trauma and also in these larger events that involve the four focus areas and to be able to improve targeted outreach and intervention for the high risk subset. Many kids will have resilience, but many may not. And we also think that if we get to that high risk subset early in the trauma cycle, with engagement of our emergency medicine colleagues and settings, we can really work together to reduce that mental health impact. Kira, you want to take the next set or
Sure.
highlight?
Yeah. Do you want next slide? Okay. So one of the things that I think we just wanted to emphasize in general throughout the talk today was just the idea that kids are often an overlooked population when it comes to large-scale disaster planning. And so it's really important to embed specific pediatric needs and steps to take in larger scale planning that your organization may do. And in addition to that, kids with special needs or particular issues are probably a subset within that. And then you layer, in addition to that, the mental health aspect rather than the physical health aspect with kids too. So you're looking at the potential for a much sort of broader and more applicable planning process using some of the CONOPS and other resources that are available for that kind of planning to really address these high risk populations, these groups of kids with special needs or pretty significant mental health challenges as well, and just embedding that into the process from the beginning. So not leaving it as an addendum or something with mental health on the edge of the outside of the plan, but really incorporating it into this trauma-informed approach. This includes preparedness resources, putting together partnerships in place with disaster systems of care. And that can include schools, it can include law enforcement, hospitals, really establishing relationships so that when something happens, you have a connection within the community of caregivers and supporters of kids that you can contact to enact a plan and work through things and have a clear understanding with all these partners from within the community about what are the first next steps and what to prioritize to meet the needs of these kids. So that preparedness and the planning can and should be sort of widespread. Getting community members and families involved with that as well, and also just linking partner groups to connect with each other ahead of time. Want to add something, Chip?
No, we are excited that the last bullet point there is certainly to engage kids that have pre-existing special healthcare needs, psychiatric special healthcare needs, developmental, neurodivergent, whatever your nomenclature and subgroups would be, kids, with mechanical device support. All of those have, even more complicated challenges in a disaster and should they need emergency medical care. And we're glad that some of our folks from the special healthcare needs components of PPN are here today, and we welcome their input as well. And then the last thing is we're fortunate that we're going ahead and developing a version of SciStart Responder, which is an evidence-based self-triage, confidential self-triage system for emergency medicine providers and staff. Also, we've used it with ICU, RCU, NICU staff. And it's a way of those that take care of kids to be able to monitor kind of their own risk without using any symptoms, and then engaging them in a preventative resilience plan that they customize to their own particular sets of issues. So that's in development now. That'll be available in the next, hopefully the next cycle for the Pediatric Pandemic Network. If people are interested in that specifically, a pilot version of that, they can reach out to me and we can let you have a look at that and some of the ideas behind it. Next. I think we kind of covered this. We know that there's science out there that basically says that kids who are unaccompanied and experience some sort of traumatic event, it could be the four focus areas, or it could be everyday pediatric trauma. A kid that has an accident on the way to school is transported to one of your wonderful trauma centers, and the parents not, immediately available as they arrive into a trauma bay, and they're facing the challenge of the context of their injury, the prospect of, being under the lights in the trauma bay, potentially secondary medical trauma related to necessary care, and that certainly makes things more complicated. I can tell you I was on scene within 24 hours to Sandy Hook, and I had interaction with some of the parents, and I can tell you that the family reunification was extremely difficult for the parents, for the kids. Basically, the kids were all gathered in a fire station just down the street from Sandy Hook Elementary. They were kind of in the back where the fire trucks are. The parents were in the kind of office area and the eating area. And basically, the governor of Connecticut stood on a chair and called out names of kids they had, that were safe in the back of the fire station. And at the end, you had a number of parents for which the governor didn't call out any name. And, they were all kind of given the message in a group format at that time. A lot of time pressures, but I can tell you that was certainly extremely difficult for those parents. Basically, it was like the worst example of, musical chairs you could imagine. They were left at the end with no chair, with no kid. And a lot of confusion, and that certainly added to the burden that, they had to deal with on top of the loss. So, I mean, that's just one example that always comes to my mind. We also had a fire here where I live in California, and this was maybe 15 years ago. And kids were evacuated to a high school in a neighboring city, maybe, I don't know, 10 miles away from where they live. And some of the parents were not English speaking. And although the location of the shelter was made on news media, it wasn't sufficiently made available in various language groups. And you had parents trying to figure out where their kids were who were not primary English speakers. And we had some kids that unnecessarily remained in the shelter for up to 12 to 14 hours. The English speaking kids were largely gone at that time. So those are just two examples from my own experience about unaccompanied kids on both sides of the equation. Kira, do you have anything to add to that?
Yeah, I've seen the same kind of a thing on an international level, working in a refugee camp in northern Jordan with Syrian families. And the same situation with Ukrainian moms and sons and daughters who had left Ukraine when there was a restriction on anyone, I think the age was 15, in any male that was 15 and older was required to stay. And so many of the refugees that we were supporting in southern Poland at the time were mothers with young daughters and sons who were too young to stay. And you had the separation with the family unit, but also not knowing and not having communication and the trauma burden on the kids that came, especially the younger boys, knowing that their older brothers and their dads were staying behind was really significant and observable. It was different in terms of the behavior that we were seeing, and it was certainly compounded, like what we've been talking about today. So you had not just what the living situation and the refugee experience that what they were having, but also the separation and the issues of not knowing what has become of my other family member, or what is becoming of my older brother or my dad or such and such and such. So it really adds another layer of complex experience to young kids because they're having trouble knowing what to make of the whole thing. And I think it's really wise to sort of consider those additional elements in the planning process for any large scale event.
And finally, I would just add everyday trauma. I can tell you that I've been involved with a number of cases when I was in the Department of Emergency Medicine at UC Irvine, where in a trauma situation, motor vehicle accident, where the parent and the kid are injured, sometimes the parent goes to a different trauma center than the kid does. It can be, depending on where they are, it can even be in two different counties the way they're transported. And it can be a period of time for highly impacted kid to not have their parent available. And that's just everyday example. Why don't we go on to the next slide if possible? I think I don't know, Kira, I think we've kind of covered this.
These are, yeah, just terms to be familiar with and ideas. Yeah, we've covered
You know,
most of those things.
I think one of the key things we know from the disaster mental health literature is um, the presence of social support is one of the key indicators of resilience. And its absence, on the other hand, is a significant indicator of risk. So for kids, especially younger kids, their parent is their primary support. And so when they're undergoing medical care and they've been exposed to some sort of traumatic event, there could be horrific sights and sounds and life threat and potentially, in active shooter situations, seeing, you know, um, ballistic wounds. It can be that much more challenging because they don't have that key support of their parent there. So we
Yeah, I think the bullet that's second from the bottom, or the point that's second from the bottom, unaccompanied status should be prioritized for mental health follow-up. That's really one of the key takeaways, I think, here.
Right. So even with other risk factors present, when
Yeah.
in addition to those indicators, they're also unaccompanied, that would be a prioritization. So, partly what we've tried to do is to organize these risk factors to facilitate surge management. Many kids potentially at risk, but who do you start with? What's the rational way to do that? And that's some of what's in our ConOps and some of these other ideas we're presenting today. I think next slide, please.
Speaking of rational way to distribute, to determine access, here we have it.
Yeah, so that works out. So this is an example of our triage tool. The system is made available across the PPN at no cost to any of the end users. It's been funded by the PPN. We have a learning collaborative, which is a way to create change using the IHI or the breakthrough series model. However, it's also available for new emergency surge incidents, even if you haven't been in our learning collaborative. Our learning collaborative is kind of the ideal way because we problem solve all the challenges. We've thought that through. But we also know there could be an emergency in your own community, and we're happy to make that available and to provide consultation to you on how it might fit into a comprehensive strategy should you need it.
I would
Uh,
just, can I
Go
add
ahead.
something that
Oh,
I just
please.
really appreciate about this tool based on what we've covered so far? That there's a component there's a component always in disaster recovery where parents who have access to more resources and make more noise to get support for their kids get that support, sort of the squeaky wheel. And part of one of my personally favorite things about using a tool like this is that it helps with the distribution of care based on actually what happened in the event. And there's an aspect of equity to care access that is not what you would typically find because it prioritizes risk based on what the experience has been. And it sort of gives kids a chance to get more pinpointed direct support for what they need based on what they went through, rather than parents that advocate well or that are, have more resources to do so. So that's one of my favorite things about using something like this.
So we've included some of the risk factors that might be found in some of the 4 DRC focus areas. Unaccompanied, for example, family members missing, multiple deaths, loved ones, that can be in a surge event. Um, Health concerns. So we know that when kids or parents have a health concern, which may be related to the uh, actual medical or health reality of that event, but also it doesn't have to be. Just the perception of health exposure, of health risk, can be extremely complicated for older kids and for parents. And they will sometimes not present with worry as their concern. They're going to present with the medical necessity. They need access to whatever the prophylaxis or the treatment is. A Mark 1 for a sarin exposure or doxycycline or whatever the current thinking is for anthrax exposure or, Prussian blue in a
Video.
nuclear event. There can be very specific perceived life-saving treatments, and that can cause a surge in addition to the actual medical surge. So, for example, in the sarin attack in Tokyo in the 90s, they had about 5,000 people that showed up in emergency rooms within the first 3 days. And about 4,900 of them could not have had any possible exposure. It was a very constrained release of sarin in the subway. I think the total number of patients was 60. There were a very limited number of deaths. And they went on the news and they said, hey, if you weren't in the subway at 5 o'clock or whatever the example was, you can't be exposed. You don't need to go to the emergency room. If you have a concern, talk to your healthcare provider. But yet, 5,000 people basically showed up looking for the antidotes because they're time sensitive. They're very effective within a certain critical window, and past that window, they're not. And the outcome is death. So you can see how that, if you're unsure, if you're unclear, if it's confusing, exposure, prophylaxis, a lot of these things are very confusing. And you add anxiety and time sensitivity to get one of those life-saving interventions, and it can definitely add to the mental health impact and consequently surge where you guys work every day.
I would add too, with regard to surge, that you can have surge with mental health come up in a neighboring community, right? That's not like you have a fire over here, and then you have kids in this other school district that can hear the helicopters and are smelling the smoke. They can really have some pretty significant anxiety around an event like that happening to them, or maybe they've seen that before, and then you show up in the ED with mental health symptoms as a function of that. So the surge can look geographically different from the actual incident itself, as well as temporally different. It can happen a month later or a couple weeks after a specific event in a specific place, which makes it a little tricky as well.
That's a great example. I'll just tell you a personal story. So we had a big fire, as everyone knows, in Los Angeles County in January. There were two main fires, but one of them burned up against kind of a mountain range. It's actually part of a national recreation area. And I have family members that live on the other side of that hill. They were not evacuated, but at night they could see the red glow. So what happens after these large fires and the smoke, the flames kind of amplify into the smoke or what looks like a cloud, and it looks like the end of the world. It looks like the inferno. And I checked in with friends and colleagues who I knew were in the evacuation area or the adjacent evacuation areas. Our own medical center at UCLA was 2 blocks away from evacuation. Harbor UCLA, we had staff that were involved, but we weren't necessarily in the evacuation zone at that point. But my cousin was irritated, upset with me that I didn't contact her because she felt a threat. I went based on the evacuation maps and the threat maps. She was responding to the red glow of the sky at night that was quite horrific, and the smell. So even though she was the opposite direction of the wind direction, she could smell it and she could see it. So that's exactly, I think, to Kira's point.
Next slide, or do you want to, anything else on this one?
Um, So the only thing is, so the ConOps idea, and I gave you the link, two links. It's one on the State Emergency Medical Services Authority here in California, and the other one on HHS Asper Tracy, which is kind of a clearinghouse. I think it's also in the PPN Resource Central. But the idea that's kind of like the concepts, and then the tool fits into that. So the tool doesn't drive the ConOps. It's a tool to help you implement kind of a organized strategy that's comprehensive. And then the tool facilitates what the training issues are, what the operational considerations are, and then hopefully helps you manage those events. I think we can move on to the next one.
Oh, yeah.
So I think everyone's familiar with the EIIC disaster checklist. You've been working off the 4 focus areas, but yet there's another in this really wonderful document. There's another domain 8, which has a lot about behavioral health, psych first aid, psychoeducational materials, and engagement of your behavioral health colleagues, and then the necessity to integrate pediatric and mental health evaluation and triage. So again, the tools and strategies that we're talking about for the 4 focus areas also kind of fit into this domain. And we would urge you to look at these also as a function of kind of where you're at in the foundational, the intermediate, or the advanced levels. And I think with that, I think we can open it up. Kira, unless you had something else, I think we could open it up to
Definitely.
questions, comments. We'll dodge Rotten Tomatoes wherever possible.
I think there's a summary page for everyone, and that's it. It's a good thing we're on Zoom, right? No Rotten Tomatoes coming through the screen.
Sure.
Yeah.
Much harder, that's for sure.
To sort of summarize the takeaways, I think today, when it comes to evacuation and family reunification, there are certain much higher risk factors for kids who are either, not with a family member or unaccompanied minor, as well as being forced to leave a home or being trapped or having delayed evacuation being a higher risk in terms of mental health outcomes. When it comes to surge, I think the conversation we just had about temporal and geographic differences, it might surprise you in terms of preparation for mental health surge because it is sometimes really not directly related to the impact of the event itself, and it can be adjacent to that somehow. And then, of course, with triage and decontamination, you can have a lot of medical anxiety and surge sometimes related to contamination as well, and surge directly related to that when it comes to mental health, panic and anxiety disorders. So just some summary points, I think.
This was great. I really appreciate you both walking us through. I think one thing I take is just why this matters. I mean, we're talking about 4 components of a very, very large response, a children's hospital response, a hospital response to a disaster. And a lot gets paid attention to physical health, and then adding in this mental health component. I think people are aware, but breaking that into these very, very real things that have happened. And Chip, your stories about the sarin gas attack and Sandy Hook, these are things that happen all the time, and only now are they getting, I think, some of the attention that they deserve. I There is a question in the chat of somebody's interested to hear who is providing the TFCBT at other sites. I wonder if you guys can talk about how TFCBT gets implemented, and then I have a couple other questions, but let's start there.
Yeah, so it's really in our current learning collaborative, which is the first time we've added the TFCBT training. And then we have a state-funded initiative in California that is UC Davis and UCSF Benioff Oakland. We're kind of advancing that a bit. So it's been mental health staff that are part of the medical center or psychiatry there. It's been school partners. In our current learning collaborative, it was just completed. I think we graduated 20 folks that are now well on their way to full TFCBT certification. They still have one more requirement they have to do, but all the things that we could provide, they've done. So we have folks from social work and psychology service at Chalk. We have folks in several different schools. We have a national best practice center called the May Institute in Massachusetts, where school staff have been doing it. We have more rural school districts in Oregon and Washington State. In our new project at UC Davis, we just trained 20 child psychiatry fellows and attendings, and they're integrating that into referrals from the ED at UC Davis Children's Hospital, and it's also on their CNL service. So they're actually starting TFCBT for really highly impacted kids while they're still admitted. We have at UCSF, we have a school health center. We have they have a built-in emergency child psychiatry response team, BERT, Behavioral Emergency Response Team. It's built into that. What am I missing? Kara, those are the main
It's the
places
main
where
ones,
it's
yeah.
been implemented.
Yep.
We did it for the state of Hawaii, not part of PPN, but after the Maui wildfires, we trained 20 mental health providers to provide TFCBT by telehealth. And that was really a combination of people in public and private sector who were willing to take essentially a Medicaid referral. That was mental health providers across the entire state. There were very few available on Maui, so we had telehealth folks we trained that were mainly on Oahu, a couple on the island of Hawaii. Some of those were people that work for the State Department of Mental Health. Some of them were in private practice, but who had contracts with the State Department of Mental Health to take their Hawaii Medicaid patients. We've tried to make it, Ryan, as flexible based on what the available behavioral health resources are in the community. And then we know that places like yours and others that are level 1 pediatric trauma centers, they have a very wide geographic reach. So that's why we've included a telehealth component to the TFCBT training. And there's a couple of randomized controlled trials out there in North Carolina where they have found that TFCBT by telehealth is as effective as in-person care for most kids. Some hyperactive 6-year-olds doesn't work so well, but for many kids, it's equally effective, if not more accessible to parents. We also used it during COVID when schools were closed in a project funded by SAMHSA in Northern California. So it also fits into the telehealth also fits into other public health emergencies where in-person care might be contraindicated.
I would also add that TFCBT has some good efficacy across culturally. That the way that it's been adapted is not, culturally specific. There's much more flexibility in terminology and how things are. It's still the same process that you follow, the same steps, but it's culturally shown to be effective as well in many different settings and environments.
Other questions, comments?
Hi, it's Liz from Cardinal Glen, and I don't know that I have a question, but it's more of a musing, and that is about where you have the intersect of multiple factors that are affecting children, right? So you don't just have the mental health, but you have potentially race-driven traumas that have come into play, plus then, language barriers or communication issues. A friend of mine has a teenager who is not very verbal, and I have regular conversations with her about just the fear of being separated, or if he's in a different place and he can't communicate, and what if people don't listen, and he's been in the medical system for a long time, which means he has a natural fear of hospitals and, you know, the loving white coat syndrome. So it's just sort of how to direct services, like, should multifactorial influences increase the priority of care, and do we take that into account with this?
I think definitely, and I think, that's really the function of this, of the DRC, is to improve strategies to be able to support kids like your friend's kid in the best ways possible. And we have the FAN component to PPN. We have parents of kids with various special healthcare needs to help us um, keep things valid for that population.
Mm.
You know, not my area, but when I think about this, I think about it's an opportunity for the family, for the parent and the kid, depending on their age, to kind of really think through how will they manage those challenges? What can they do to improve that? I can tell you a number of years ago, we had some funding from LA County Public Health to improve uh, pediatric preparedness for kids with various special healthcare needs. And I don't know if you're familiar with the um, joint AAP ASEP emergency form. It was developed a number of years ago. I think, Laura, maybe you were AAP. And, it basically allowed the provider in the pediatric home to say, hey, here's what the baseline is. So if the kid went to an emergency room that didn't have any access to medical records on that kid, didn't understand what was going on, and the kid had all these abnormal baseline, imaging or other kind of indicators, they wouldn't start treating things that were already well managed. Also, if you had a kid that was, on a very precise cocktail of psychopharmacological medications, they wouldn't have to reinvent that. And we, worked with that to push that out, to build some training. And then we converted that AAP emergency information form to a backpack tag. So the little form could go inside kind of a silicone encased backpack, tag. The information wouldn't be visible, but it would kind of be, break the seal when necessary so that that information could be shared. So to the extent that um, the kid and the parent can think through very simple ways to communicate that, should they be separated, should there be some sort of an event, I think that's the way to do it. If it's a kid with a special healthcare need, I think talking to um, the providers in their medical home about using that form or something else is kind of the best we can do at the moment. I'm open to other of our special healthcare needs experts with their inputs. I don't know if they're all still here. I think is Janet still here? No.
I think the part that is of interest to those of us that know a little bit about mental and behavioral health, but not a lot within disaster settings, is so you've got 5 things going on, and how do you prioritize what to do first and where to go from there?
In terms of mental health specifically, or in terms of,
No, everything combined.
Well,
Where do you start?
well, obviously, it's life-saving care and ALS and resuscitation. What we've tried to do is, in terms of identifying risk, is to use risk factors that you're already learning about in the mechanism of injury or the history of present illness that are
or
already,
the rescue, whatever happened during the rescue itself.
Exactly. So, and that could be in a paramedic run report. So a lot of the things that we consider kind of the key risk factors, those, the ED, especially a trauma center, they're probably already learning those. And we're just repurposing those indicators toward the mental health next steps that would follow on. So we actually published a feasibility paper. You can get accurate mental health triage within the context of a pediatric trauma activation. It does not disrupt care. There's ways to do it. In that same paper, we basically had a trauma director, a trauma surgeon who made triage part of QI and made it a standard for a pilot project. And, we went to 100% compliance, almost instantaneously. So it is more work. It is thinking outside the box, but on the other hand, it's also feasible.
And it doesn't add a ton of time. When you're in a hurry and you have to be prioritizing things pretty quickly, you're already collecting that information and multi-purposing it, like Chip mentioned. So it's minutes. It's not, hours of work.
I mean, we also know that the mental health impacts can be some of the most enduring and tied to longer term impairments such as school failure and secondary depression and school avoidance. So we think there's an advantage, and Kira and I are working on a study design now to show, hey, if we get to this high risk subset very early in the trauma cycle and intervene with relatively brief evidence-based practice, it's not psych first aid, it's not likely to be sufficient. There certainly isn't evidence that it is. We think we can interrupt that, alter that trajectory of risk in a cost-effective way, and also that benefits the individual child and their family. So we hope that's the future moving forward.
I had one other question, which was, and I think this goes to Ryan's question on TFCBT and getting some of this. You find out the risk. Now, what do you do with it, and where do you find the providers? Is what is the best way to go about finding your community behavioral health and really establishing that relationship? Because we say that all the time, but especially in areas I haven't, a lot of the mental health providers are already, stretched very thin. And now you're asking for a very worthwhile thing in an acute disaster, which is establishing that so we can have that kind of follow-up. So is there a best practice? Like if people are reaching out to you or your colleagues, like what has hit? What has been that model of saying, what can we say that says, okay, this is now going to be a value add to your practice. This is going to be something that we can work on. We can establish that relationship.
Well, I think a couple things. One is there's an increasing emphasis in payer systems. I think we're going to see it increase in the near future to use evidence-based practice. So there are several different evidence-based practices for kids who have traumatic manifestations like PTSD. However, TFCBT has been identified, just a recent review. There's a Cochrane review from a number of years ago. There's something that was just published in JAMA Psychiatry in December, basically saying TFCBT should be considered the first line consideration. But it doesn't have to be TFCBT. Some evidence-based practice is indicated. When we train TFCBT in the Learning Collaborative and in our other projects, we train it as stepped care. We've been able to work with one of the 3 TFCBT developers to offer the intervention in 2 steps. So it's basically 4 modules, then they're reassessed clinically. And in projects in California after fires and floods, and in the state of Washington after COVID fires and floods, somewhere between 50 and 70% of the kids are sufficiently improved they can stop the intervention after just the first component. So the advantage, I would say, to your partners, Chris, is it's extremely efficient. It's a way to distribute limited mental health providers in the most efficient manner using stepped care. So the addition of stepped care over more traditional delivery of trauma mental health care really adds much greater efficiency. And the use of the triage system allows you to float the algorithm to the highest risk subset sooner rather than later. SciStart's red risk factors are largely multivariates, not all of them, but the vast majority. So they're independent predictors. And when you add their independent risk together, you're getting additive, at least additive, if not geometric risk prediction, we believe. And that's, again, another way of efficiently organizing an evidence-based resource. So, yes, it's going to take some time to learn TFCBT, but in the end, you're going to be getting the best practice for trauma. And in the way we train it in the steps, it's extremely efficient. So, what we found is using the step model, an individual clinician can treat two, maybe 2.5 times as many kids as they would using the traditional model
In the same time frame.
in the
Also.
same time frame.
Yeah.
Thank you.
Just to add that.
Does that help, Chris?
It helps me. I hope it helps others. Well, I thank you again for both of you for this incredible discussion. Laura, I'll hand it over to you.
Sure, next slide. Those of you who have been part of the DRC are familiar with this process for collecting CE. I put it in the chat earlier. I'm putting it in again. It involves the code that you see here. If you have any trouble, just let us know. And I did want to thank our speakers, Chip and Kara, as well as you, Chris, and all of you for attending. This was a very high quality fireside chat, but relaxed and nice to learn in this type of environment. Thanks to Julie Shelton for running the logistics side of things. And Julie, you can go to the next slide and tell people what they need to know about the session evaluation. It seems pretty clear, but go ahead.
So if you take your phone, take a picture of this QR code, you now, instead of having the session evaluation pop up on the screen through Zoom like we have been doing, you can just open it here and then it will go, you can keep it up. You don't have to stick around and complete the session evaluation. If you need to hop to another meeting, you can do it, just keep it up on your screen and you can do it right there. One thing I did not do is have a backup, and so that we could put this in the chat.
Julie, there's a comment saying that there was a closed comment. I will check.
I did the texting of the code and it said that it was closed at 10 a.m.
Yeah, that was mentioned earlier. So we will follow up with our CE person. Try the other option of going in through the CE platform. And if you still get a problem, at least then we'll have an email trail that we can forward to the CE folks, and they are very helpful. I did not have problems with the session evaluation, so that's good to know.
I just wanted to say thank you for hosting.
Yeah, thanks for having us. We really thank the DRC for its vision to include mental health on the front end, and actually the PPN mental health has been on the forefront. It's one of the key domains that Kira, Chris, and I are part of, and I think that's the way we move the ball forward. So we're so overjoyed really to be part of this effort with all of you and our pediatric EM colleagues. Keep up the good work. If you need us, you know where to find us.
And thank you for sharing your expertise with us. And if the speakers would like to stay for a short debrief, you are welcome to do so. And other people can remember to close their browsers when they're ready to depart. And thanks again, everyone.
Thank you.
Bye,
Thank you,
everybody.
everybody.